What you get a
Yeah,
new?
saying Zoom is unable to detect my camera,
Did you get a
which is
new
very odd.
new computer?
No, it's the same computer as always. The only difference is that my son has been on it.
Oh,
Blaming his son.
yeah.
Well, if the only difference is my son, then that's the only difference, you know?
That should teach you better. I mean,
Well,
doesn't matter. They will get to see the handsome Delgado,
Yeah,
the
yeah, we'll
original.
figure it. Yeah, we'll figure it out then, I guess.
everything falls in line.
I'll play with the settings and see if I can't find it. So if I accidentally
Pop.
jump off, it's because I was playing with it.
Okay.
No
But
worries. Are you guys faring
that's
well with
just
the
like,
storm over there in St. Augustine, or what's the
what
deal?
storm, dude? It rains harder than that on a random day.
That's true.
I know.
Like it was nothing.
You know they always blow it up and make it seem worse than it is. It wasn't too bad here as
No,
well. I had a
it's
couple flickers in the power, but it wasn't nothing crazy.
I have one branch I had to pick up.
yeah, I didn't even have that. So
I had a
nothing
few.
close. I mean, the only thing that closed for us was the banks, which was a pain in the ass, but that's a
True.
different problem entirely. So, but yeah. So, but yeah, I mean, you guys ready to jump in?
I
Let's
was
do it.
ready.
Let me get my screen up. I just got a small PowerPoint put together, but obviously we'll keep it conversational for the most part. But give me just a moment and we'll get it going. You guys can see and hear me okay, correct?
Yeah.
All right, great. Let's do this. Let me know when you guys can see.
I can see. When I
Yeah,
woke
we
up
can
this
see you
morning,
just
I
fine.
opened my
Oh, but I
eyes. I
mean,
was
you
able to
mean the
see.
As long as you can you see the presentation or the PowerPoint?
Now we
yes.
do. Yes.
Sweet. See how many we got on here. Christy, how's it going? Don, good to see you. Natalie, welcome. We're gonna go ahead and get it rolling. By the way, I put some links in chat. Today's topic, we're gonna be talking about the Medicare Advantage trends and challenges. This is an article that Dr. Delgado had put together. If you guys find the time, please look through it. It's very beneficial. I also posted a link to last week's webinar session we did with, for those that did not attend, was with Sam Prokop, who is an attorney for Gunster Law here in, they're based out of Florida. And we talked about mergers and acquisitions. So I put the link to last week's webinar in there. Don, it's in the chat. You should have an option. I'm not sure what it looks like on the non-host perspective, but there should be a chat option there. You click on it, you can see the links that I posted in there. But hey, we'll go ahead and get started. Welcome everyone. Thanks for joining us for today's session. We're going to be talking about EPICompliance Leadership Insights, Medicare Advantage Changes with our CEO, Dr. Jose Delgado. Dr. Delgado, welcome again. Glad to have you on for another session. For those that don't know, Dr. Delgado has over 25 years of experience in healthcare consulting and is a renowned healthcare executive working with many hospitals, healthcare practices, and various healthcare businesses. He is also the founder of EPICompliance, which was founded in 2013. EPICompliance offers streamlined and simplified compliance processes for healthcare businesses, business associates, and students under HIPAA privacy, HIPAA security, OSHA, and Medicare and billing compliance regulations. Again, Dr. Delgado, excited to have you here today. Was there anything that you wanted to add to that introduction?
There's way too much. It's actually more important to see what is it that our participants want to know, because the topic itself is something that is happening in all of the commercial insurances as well. But it's just some people just want to know more about Medicare Advantage. So I can tell you more about that, and that is the plan today. But where do you want me to start?
Well, before we get there, right? Because I think all of this stems from the federal government, right? Because Medicare Advantage is a federal program, even though it's run by private organizations, the the federal government is highly incentivized in pushing more Medicare standard to the Medicare Advantage. With the final rule coming out that hospitals are getting a 2.9% bump and outpatient offices are getting a 2.9% decrease.
Mhm.
Yes, that math equals out perfectly for everybody listening. That hospitals get 2.9% more on top of their other bonuses that they get on their payments. And we in the small offices and in outpatient settings are getting a 2.9% decrease. So, do you think that's why Medicare Advantage, there are more consolidations going on? There are more people dropping patients because they're getting hosed on that end too, on the per patient basis, because that's a full risk model, right?
It is, but let me step back for the benefit of our participants, okay? Because you jump straight into Medicare Advantage, and there's an
Well,
easy
I
way.
went the whole route in 30
I,
seconds. That's all.
I understand, I understand, but let me give them something that it make them easier to understand, okay? Basically, we're talking about 4 different parts of Medicare. Medicare Part A is the hospital. Medicare Part B is outpatient. Medicare Part C is Medicare Advantage, the managed care program. Medicare Part D is the medications. So when we talk about Medicare Part C, which is the Medicare Advantage product, because I have a question from one of our clients before about that. He say, do I need to treat the patients the same as if I was treating Medicare? And the answer is no, because yes, these are Medicare patients that opted to have a commercial product. So the rules change a little bit. Not only does the rule change, but also Medicare Part C provides, depending on the insurance, additional benefits to the patients. The problem is, where is the money? What happens? And even to the point of what is managed care. So to Jose's point about the decrease, it has already been determined many years ago that Medicare is going to stay in a neutral aspect. So that means that they're not going to add any more funds. All they're going to do is move it from one side to the other. And even the portion that goes for Medicare Part A has been used for other uses other than hospitals. So that's why hospitals are screaming bloody murder. That's why you're going to actually see hospitals in smaller areas that are going bankrupt. They cannot keep the doors open. Hospitals don't have the choice, for the most part, to select who comes through the door. And this is where the indigents and all of these, I would say, illegal aliens are coming in, and all of them are sick because they don't have medical services. So they're coming into the United States, going to the hospitals, receiving all of these services, and then guess what? Who pays for that? Well, that's the problem. There's no money. So the government has to find a way to fund the hospitals or see that they will continue to basically close the doors. So we're going to see
Indigents are
more and
covered
more.
under Medicaid, not Medicare. Medicare yet is an opt-in program.
Well, but the thing is that the illegal aliens are protected under the federal government in a way. So that's why they're trying to put the money from the federal government, not the state, because a lot of the states are not in agreement with what's going on. But let's
Yeah.
go even further, because you touched another part when you were saying, okay, what about the money? What are we going to do with all of these things? What is happening? Well, one of the things that is also happening, and it's not just with Medicare Advantage, but it also with managed care altogether, is that people underestimated COVID. Okay. And we say, well, COVID, we're talking about years back. Well, the thing is that between COVID and the vaccines, we're now seeing secondary effects that basically increase the risk, which basically cause many of these companies to have profits less of what they expected. So one of the things that they started doing early this year, actually late last year, early this year, is we need to increase our reserves. Because if they don't have the appropriate number, and this is money, on the reserves, then what happened is that Medicare will come in and say, you don't have the reserves to cover the expenses for operations, we're going to take the contract away from you. So how do they build the reserves? There's only so much money available. Well, what they do is that they take the money out of what they pay to other people. So like, for example, for some of the MSOs, managed service organizations, that they are at the full risk. They say, oh, you're full risk. You're on this with me. So instead of you receiving $2,000, and actually I'm dealing with some people that instead of getting $10 million this month, you're getting five, because I need that $5 million from you to build the reserves so that we can continue to operate. It is your money, you earn it, but we don't know when or if we will give it back to you at some point in time. So what we're seeing is a shift in terms of risk. Managed care is risk. Managed care blows away the concept of, okay, in most places, and let's put some basic example. You go to Walmart, you're going to buy milk. Well, okay, for the milk, okay, maybe $5 a gallon now. I don't even remember anymore.
It's up there.
So yeah.
It's 450.
Yeah,
Okay.
it's getting there.
Okay, thank you for that. Not that critical to have this right number, okay?
Oh, it's critical.
Oh, it's critical when your grandson's drinking it as much as he is.
I know. But the point is, you get a product, you pay for it. That was the model that we use in healthcare. It's a fee for service.
Yep.
I get somebody to see me, I pay so much, and that's it. Well, in managed care, the concept of managed care was, no, we're actually going to pay, and this is from Medicare, we'll go to the insurance, say, you have for this patient $25,000 for the year, and that's it. So it is up to you to actually make it work and take care of all of the, I would say, issues of that patient. Well, fine. So insurance companies are there to make money. They're not there to provide service. So the insurance company will come and say, okay, fine. So if I get $25,000, I'm going to say that my overhead is 20%. So 20% of that is gone. The rest is what I'm going to use to pay for the services. But guess what? We need to show profit, because if we don't show profit, our investors may take the money out and we will be out of business. So what I'm going to do is, for this service that Medicare pays $100, maybe I will pay $80. And then I look around to see, well, maybe now I can go to 60. I mean, it got to the point, and this is actually going back 30 years, how everything started to move to where we are now. So at that point in time, managed care, we're still paying based on fee for service, just that they manipulated the schedule. And in some of the contracts, bless the soul of some of my clients, when I told them, they will actually put on the contract, we will pay you based on Medicare fees. But based on Medicare fees is not the same as Medicare fees. Based on Medicare fees, it will be, we use this number as a base. So it could be 20% or it could be 80%. I remember one in particular, internal medicine, nephrology, that he said, oh, I'm getting paid Medicare fees. I said, really? Yeah. Look at my contract. It says Medicare fees. When I look at the contract, it says at 20% of Medicare fees. Say, you're going bankrupt. You don't know. Okay. So now we have moved to the next phase. And let me just add one to that part. The other problem was Medicare, based on Medicare fees, from what year? Are you talking 2013, 2024, 2020? It got to the point that you never knew really what they were paying you. So what I started doing for my clients and myself was, here's my fee schedule. Fill it out. Tell me how much you're paying me for each one of these services. At first, we had control, so they did it. Now, good luck trying to get them to fill that out, because it gets almost to the point that they don't even know, the people you're talking to, how much they're supposed to pay you by contract.
I can tell you right now that most of them don't know.
I know.
Because when we talked to them with the mental health practice, half of them were like, I don't know what the fees are. Well, then find me someone who does. I'm sure you have a spreadsheet you can send me, and you're talking to 15 people and not one of them understands what we're even trying to ask for, much less how to get it.
Yeah.
And then it comes out that it's $45 for an outpatient visit.
Yeah. Like I said now, but the problem is that we're moving into the true managed care. Managed care basically, and there are ways to make money with managed care. What it means basically, managed care is that I'm going to have this person, this patient, everybody's going to die. Let's be clear about that, because unless you know something I've done, everybody will die. But in order for me to make money under a managed care environment, What I have to do is keep that person as healthy as possible so they don't spend the money in the hospital. They don't spend the money with multiple procedures. They don't spend the money just getting medication that is very expensive when a generic will do. But that takes time. Okay, we do have a raised hand, Natalie. So, Ray, do you want to handle Natalie or
I
do
was
you
going to
want
say,
to?
Natalie, I'm not sure if that was intentional, but if you have a question, please feel free to put it in our chat. You should have a chat option there to
So,
add your comment.
Dr.
Wait,
Delgado, I do have to jump in since you paused right there.
okay.
This whole managed care definition just seems like the new version, a new spin on HMO.
It
You know what
is.
I mean? Like it's HMO by another name.
It
You
is.
know, because it's all about maintenance rather than actually treating the problem or being innovative or anything like that.
Okay, so now stop there because there's more to that. This is a nice way for them to say that I'm actually taking care of the patient.
Yeah.
Reality, it's not about that. It's about the money. Okay. In reality, managed care, when you really look at it, what they're doing is managing the cost, not the
Yeah.
care, because it's the only way that they can make money. What I'm telling you is that as a healthcare professional, we have an obligation to take care of the patients. So how do we do it? If managed care, and basically this is where everybody's going, all of this is about macro, value care, all of these measures are just an excuse for them to pay you less. Oh, you
Mhm.
score less on this, you score less on that, you score less on that. So now we're going to be paying you less because on all these values you are not meeting. So what they're doing is just that. Now, what we have to look at is then, okay, what is it that we have to do to make money? But what else is happening? And this is where you get the problem that insurance companies, not all, but quite a few of them, are getting into trouble because they are not meeting the requirements of the contract. In the blog that I wrote on Sunday, that the one that Ray referred to, the Office of the Inspector General did an investigation. In that investigation, they found out that 18% of the claims that were actually sent, that were approved, were covered services, everything was done right, the Medicare Advantage didn't pay. And there's other numbers about 14% here, 14% there. So what it means is that if you are not looking and you're fighting it, and like Jose say, nobody knows what's going on the other side, but they are playing all of these little games. If I keep $20 of one visit, that's $100 of one surgery, the physician is going to say it's not worth it. Let's move on. Well, $100 times 1,000 times every week makes for a nice little profit at the end of the year. So what are we to do? Then the other thing is not only did they fail to pay, they fail also the ones that they paid late. So that means that you have to be harassing them to get the money for services you already cover. But
Yeah.
now, because we're going into the risk model, I'm actually working with one particular client that by the time he sees a patient, which most of the people are going to be there in risk. Well, okay, so let's say that, Ray, you are a healthcare organization. You're going to sign a risk contract with me. So I'm going to pay you per patient per month, right? And let's say that I'm very cheap. I'm going to pay you $1,000. And that's very cheap. That's garbage. Okay. But it depends on other things. Keep it simple.
$1,000 a month or
Per
$1,000 for the year?
patient per month.
A month per patient
Oh,
per
that's
month.
all right.
Yeah. But the problem is, but I cannot pay you that or adjust that until I receive the data that you need to send to me. Once I receive that data, then I'm going to calculate. And then after I get that, I'm going to send it to Medicare. Then Medicare will approve it. Then I'll start paying you. So that means that in the process of once I see the patient, I have to do all of the codes. Okay, this is the patient,
Yep.
this is the condition, this is the
Turnaround time.
chronic. So now you send it to me. Now I process it. The bottom line, it takes about 15 months for you to start seeing money for that one patient that you saw in January, the first of the year. So the
15
risk,
months.
15.
That's an
That's
average.
Yep.
Wow.
Over a year.
Yeah.
I
So
better
that's
be seeing a bunch of patients then. That's all I would say. That's all I
well,
could say.
It's not worth it. You're in the
well,
hole for a whole year and change.
okay.
That's unbelievable.
Okay, calm down, guys. They don't do it just all of a sudden. That's why when they go into this contract, they say, okay, you are only going to have 50% risk. Then you're going to have 75%. And then it takes like about 2 or 3 years for them to give you 100% risk. And people say, great, I'm going to be making money. No, you are not. Because if you keep doing things the way you have been doing it, you'll never make money because all you're doing is, and they put it like, oh, on the savings. Well, what are the savings?
Yeah.
Well, managed care. Well, did you see the savings? Well, if I'm doing my job right for that patient, I shouldn't be seeing any savings because I'm not wasting any money. So
Yeah.
where's the money I'm going to get? So when you really look at it, this is quite complex, and I can go through all of the different numbers, formulas, specialties, and all of that, but that will go way over. The bottom line here is that because of what is happening right now, there are multiple organizations, like for example, UF, University of Florida, that have multiple hospitals that they have opted not to take Medicare Advantage anymore. And again, it's not all of the products, all of the companies. And again, understand that when you're talking about managed care, well, I'm talking about Humana. Well, Humana has a couple of managed care products. So it's not just an insurance, it's the product that they're looking at. So we're not taking that. Then you go to other hospitals, and when you really look at it, there's quite a few hospitals that are saying no to Medicare Advantage. No, I'm losing money as it is. Now you want me to wait. Now you want to put the risk of me. Why should I be taking money? But the interesting part is what I see in right now, because the model of managed care actually benefits primary care practices. Because now it goes back, like Jose was saying, this is a capitation, HMO, gatekeeper model. So the gatekeeper normally is the primary care practice. But what they have done different from the 1990s, I would say, is that now they're allowing different specialties to become one organization that manage that. That's why you see more of the Medicare Services Organization. I mean, Management Services Organization, MSO. So that organization is going to manage that for everybody in that pool. That is also where accountable care organizations, PHO.
Yeah.
I can kill you with all the different acronyms. But the idea is that before you couldn't do that, because that was a kickback. You were working with your competition and controlling money, and everybody was working together. And what about,
Controlling the market.
yeah, which is what is happening right now, because there are less people being able to stay in the market. So what happens? Then the bigger monsters are taking the market. A hospital, a small hospital, cannot survive anymore. So what do they have to do? Well, they have to go with Advent, Baptist, I mean, UF. It depends on where are you, and those are the ones that are becoming monsters. So the market, people say, oh, are we going to go into socialized medicine? Well, it all depends. What is your definition of socialized medicine? Is who's controlling the service? What are the services you are receiving? I've been talking with actually groups of practices. And group of practices, I'm talking about fairly small, 4 to 10 practices. Okay. So what they have done to protect themselves is that they say, okay, we will accept you as a new patient from this Medicare Advantage, but we do not have any openings to see you or establish you for about 6 months from now. Why would you do that with a new patient? Because you want to make sure that you receive enough payment from all the established before you start seeing new ones, and you want to control the new ones because you don't know how much you're going to get paid or when are you going to get paid.
And you don't know what you're walking into.
Exactly.
So if they're high risk, they're not going to be able to wait that 4 to 6 months. They're going to have to go someplace else, which means that, for lack of a better term, you're discriminating on the types of patients you're getting, which is also supposed to be a no-no in the Medicare programs.
It is true, and that's the case. But then let's talk about what are the no-nos. What about the phantom networks? What is a
Oh,
phantom
I'm not
network?
disagreeing with you. I'm not saying that this isn't the way to game the system. I'm just saying that if we're calling a spade,
Yes,
this is a spade.
yes, it is.
You know,
I'm not in disagreement. I mean, let's put it this way, people, okay? Because this is the important thing for not only for us, but for everybody else. There is healthcare will always be out there. Healthcare, depending on how you do it, will always be an opportunity to make money. Healthcare, at the end of the day, there's so many advances. I mean, so many advances in the medical that you say, wow, the things that I can do for a patient. But the problem is the following. You need to learn the rules. You need to learn, where am I going to? What am I doing? What are the gains? Because there are people in different places that all they're looking is the numbers. How do I make money? So in case of the phantom network, what is that? Well, by contract, these insurances need to be able to provide access to their patients to all of the different specialties, period. That's what it is. But what happens? Well, if I say that I have let's talk mental health, because that's the thing that will get Jose going. Okay. So in mental
like you
health,
need much to get me going.
I know, blame your mother. Okay, but
Yeah, all
let's
right.
go back. When we look at that and say, okay, how easy it is in today's day and age to get an appointment with a psychiatrist. And when I talk with
Usually
different,
industry average is 90 to 120 days if you're lucky.
yeah,
Why
but
so long?
Why so
well,
long? One, because psychiatrists are bloody unicorns, but also because there isn't so many of them. If you're looking specifically for a psychiatrist and not a psych mid-level or an MD, a primary care doctor that has experience, there just aren't many, and there's a ton of situations that you at least want the consult before you kick it back to primary to manage.
yeah, but
So
there's
you can
more.
have a psychiatrist just buried in consults.
Yeah. So let me be the salesman. And there is more to it. It's not
Yeah.
just that. The other thing is that for me as an insurance to make money, I don't want the patients to go to the psychiatrist too often. So instead of having one psychiatrist for 5,000 patients, I have one for 10,000 patients. I'm still paying him on a capitation. I'm paying him the same thing every month. The 10,000 patients will never be able to be seen on a timely basis. So that shift everything out. Now, but the insurances are actually doing worse than that. They're saying, yes, I have a psychiatrist. Well, when they give you the contract, and this is what you need to know when you are looking at contracts, a contract with an insurance, and let's pick now on Blue Cross Blue Shield. Well, Blue Cross Blue Shield have over 50 products in any one market. Okay.
Yeah. In
So
any one Blue Cross franchise.
right. So what they're trying to do is in that thing, they say, okay, we're going to give you the PPO, we're going to give you the traditional, we're going to give you this, and that. But among that, they will also put the Medicaid product and a
Yep.
Medicare Advantage product that pays very poorly.
And the Obamacare product they have for that market too.
Exactly. So you, as a practice administrator, have to look at it and say, I don't want all of those products. The only products I want are this, and that. But you
And they
already
tell
signed the
you take it
contract.
all or don't take any of it.
Yeah, but again, in some cases you do have control. So in those cases that you have control, Blue Cross Blue Shield goes to the government, Medicare, and say, hey, listen, I do have a signed contract with that provider with us. The fact that you're not taking Medicare Advantage, oops, it was an overlook. So all of a sudden, and this happened to us even when we had the clinic in Jacksonville, is that they will see the name of the provider on the network when they call, we don't accept that product. Well, but you are on my provider list. Well,
Uh-huh.
but we don't accept the product. And the patient will die telling you, I'm going to complain. You are supposed to see me. I'm a patient. No, we're not. Your insurance company put our name erroneously. There are times that we don't even participate with insurance and they will put your name there. So Washington have caught up that and they say this is a breach of contract. They are supposed, and they have been looking at this for over 2 years. So they
They
are
haven't
supposed to
penalized
move.
anybody yet.
No, they haven't moved.
They've
And it's
wagged their
Finally.
finger. They've embarrassed them on C-SPAN, but there has not been one fine. There has not been one contract pulled. Nothing in that respect.
yeah, but remember, Jose, what we need to do here is provide a very, I would say, factual information. What is
Agreed.
happening? What is it that we need to do? How do we move forward? Okay. And like I say, I actually have one clinic, physical therapy, that I work with, that they signed one of these group contracts. So the problem was they never, and they, to this day, as far as I know, they have not been able to determine how much are they paying them for their services, for what they are actually doing. So every month they get a check, but how do you match that to the patients that have been seen? How do you match that to the services provided? You don't know. I have another one that signs in, and what they did, they took all of the patients, moved them to another provider, and all of a sudden he has no practice, and he cannot compete to get out to open the practice because he has no compete with that. Which the good thing is non-competes are going away based on FTC, Federal Trade Commission,
FTC.
FTC, Federal Trade Commission. Okay, so that is going away, but the key thing here is, what do we do? What are we going to be looking in terms of Medicare Advantage? Is that a product that I want to participate with? And in reality, it goes from person to person, practice to practice. You will see it because everybody's seeing it, the payment delays and dispute. You will handle the phantom networks. Given. Now, what is the employer doing? What are the people doing? Okay, give me a second. Let me get a glass of water. Jose.
Yeah. So I guess my biggest problem is seeing this seeing this day to day, and then dealing with this stuff as well. It's not that I'm black-pilled, it's that the playing field is not level. It's not level insurance versus people actually doing the job. It's not level hospital versus outpatient. It's frustrating to me, and it annoys me so much that I have to sit here and follow all these regulations and rules and hope that I don't trigger an audit from pick an alphabet agency, but all these idiots can do whatever the hell they want, and they get a finger wag. You know what I mean? Like, and I know it's about the money. We don't have the market cap that they do. And I know that part of it with the contracts is this is why you want to work with the private equity, like we talked about last week, or an MSO or an ACO, because then you have the amount of lives to have some leverage. But it's one of those things that it just grinds my gears and makes me want to just burn things, you know? Like, for lack of a better term.
Okay, wait. Okay, let me get back here. Everything that you see that is change is an opportunity. So
of course,
what that is happening is that some companies and some individuals are saying, why do I have insurance? I'm going to pay cash. I mean, the move that we did with Panacea, going from taking everything to now only taking cash and Medicare traditional, was a good move. It hurt for a couple months, but then the patients came back with a better cost. We'll pay you cash. So if you need to know your market, you need to know your product, you need to know what is it that you're trying to accomplish. The other thing is the admin, the paperwork you have to do, because it's not just the paperwork. And this is what I was talking about, Medicare Advantage, that you have to basically do the MRAs to send to Medicare, to send to the company, to Medicare, for you to get paid based on the risk of that patient. That takes time. And it's not just putting, okay, the CPT code, the diagnosis is this. It's supporting. You cannot say the patient has COPD. No, what is the treatment plan? How do you determine? What are the numbers for that patient? All of that paperwork without even getting into the compliance issues. I mean, right?
It's like adding a middleman on a process that was already cumbersome and slow to begin with.
Well, when you look at this thing, because Medicare Advantage is different than Medicare, okay? So all of the things that you had to do for Medicare based on MACRA, the safer guides, the SRAs, all of that apply to managed care, but a different way. Managed care doesn't care that much about MACRA and MIPS. They have a different rule of how they're going to pay you, but they will still enforce the SRAs. They will still enforce certain paperwork, certain administrative burden. So what I have done, like I said, I try to be positive. So what are we doing? Number one, believe it or not, that's why I created what it was Taino compliance that then evolved into EPICompliance. I don't have time to document everything that they want me to do, all the policy checklists, all that on a daily basis. So what I do, put it on EPI, we all do it together. Now I have less of a burden to follow with this thing. Second, so now I can look into the numbers. What makes sense to me? Do I want to play with one of the big boys so they take a bigger cut, but I reduce my overhead? Or do I want to go on by myself and do the deals? And that's one of the things we got to look. What are the deals to be made? Because the way we're going right now, everything is going to go into some kind of risk. They don't want to pay you anymore fee for service because they say, all you're going to do is increase the numbers. But there is another risk that is happening, and you're going to see in this coming year a lot more. The Office of the Inspector General has determined that the Medicare Advantage products have been spending billions of dollars that they consider to be unnecessary. Wow. How do they come up with that? Well, yeah, reality is that there are some people, and this is where it comes with the hideous scores, the 4 stars, 5 stars. Or they're telling the doctors, I want you to document this, and this. The templates that they use on EHR. Because by doing that, they maximize the points that they're going to get, and they maximize the money coming in. So yes, there is a section of the industry that is doing that. And it is, I mean, for me, it's easy to identify, but I'm not going to say any one of those things on anywhere that it can be recorded. But you can see the people doing it. So that means that, like Jose say, it's not a fair, even field that we're playing. You want to do the right things, it takes more work. You have to be efficient. Goes back to look at your resources. What do you want to do? How do you want to do it? Okay. So there is going to be more audits coming down the pipe. And I have, again,
Rocker.
I have a client that is being hit by a couple of those already. And it's because of the money. So they're going to look at it and say, well, you code for this thing too many times. So next year, we're not going to pay for that. That's one thing. And I've seen that happening across the board.
Macro did that. Macro Meaningful Use did that. It used to be, and the easiest one to point out was, oh, we want you to do, they use the carrot method of, oh, we want you to do all your prescriptions electronically, and we'll count that as points. And then as soon as they got enough people to do it, they took it off being worth any points at all. Because, oh, everybody's doing it, so now I don't need to incentivize you, so here's the middle finger.
Yeah, but then again, look at it from the standpoint, oh, you're telling me that 100% of your population have anxiety. Well,
after COVID, yeah, I could have told you that easy.
Yeah. So again, any of those things, because everything is tracked by computers.
Yeah.
And actually, I saw the proposal many years ago. They sent it to me in case I wanted to be the one developing the software to do that. And what I did was I look at all the requirements to look at it to see what I needed to do to protect our clients. Okay.
Yeah.
So that is happening, and it's going to be more. They're going to continue to look and very closely, and you're going to see more audits, and it's a way for them to defund certain organizations. Like I say, everything is going to be based on risk. Unless when you look at your contract and you say, no, you're going to pay me so much for this service, forget about the rest, or you are really good at managing risk. I mean, I work with one organization that we are training the doctors how to do it, and there's money to be made. So yeah, you can do like that. So that's why I say it depends on you. The next thing is technology.
Mhm.
I actually had my own EHR, and I mean one that we created 25 years ago. But that EHR was based on the needs of the practice, not what the government identified that we needed to do for them to track. So technology can help, but you need to know what technology is the one that you want to have in your practice, because otherwise you will end up paying licenses, fees, upgrades, updates, server, all kind of crap. What is it that you really need to be efficient and then implement that in your practice? The other thing is people are getting tired. And I'm not talking about, well, actually, I've seen a portion of the geriatric market saying, I don't care what they are saying. I'm not going to keep
Yep.
taking all of these pills. I'm not going to do this. I really want to be healthy. When you really look at the actuaries, you will
Yep.
see that now it's not uncommon to see an 80, 90-year-old patient active and moving. Before, and I say before because I'm almost there with those geriatric patients, you will see a 65-year-old patient or individual that couldn't move. It
Yeah.
was spending the afternoon rocking in the balcony. I mean, I'm getting close to the 65. I get up in the morning, the minimum I do is 200 push-ups and 300 sit-ups. I'm
Yeah, but
done.
even in your case, we're talking about, there are some the majority of our patients, and I guess it's because I'm in a specialty, but if they're Medicare, it kicked them in the teeth. You know what I mean? Like that was not an easy 65. It's a hard 65. You know what I mean? Man, I've even got some 40-year-old patients that they look like they're on Medicare, but really they're 40. So I mean, it's when we're talking about the patient populations, yeah, if I can skew and just, I mean, let's call a spade again, discriminate towards the healthier model, the healthier patients, then I can make more money on the value base. But that's the same. But then we're literally becoming the insurance because that's what the insurance does with rates. Everybody at a certain age gets paid a certain amount, and the only reason why the insurance is even viable is because you have the two extremes on that bell curve. You have the super healthy patients that don't use any services, and then you have the super unhealthy patients that the providers, the ER, and the ambulances know these people by name.
Yeah, but there are ways that you can still provide a good service and make money on those patients that have chronic conditions. But my point
Absolutely.
here is that because we have a healthier market that wants to remain healthy, they are willing to spend money, those that have it, into those things that will help them. And those are the
Yeah.
things that most of the time, those services are not covered. I mean, like for example, the stem
Yeah.
cell. I swear by stem cell that it actually helps, but we don't get paid. As a matter of fact, FDA has so many restrictions, won't let us do it. There are actually ways right now to cure diabetes, but it's not to the benefit of I would say the pharmaceuticals to cure diabetes. You know how much money runs there?
Mhm.
So there's good and bad. Don't judge. The point is, this is where I am now. So what can I do to make it better for my
Mhm.
patients, my staff, and my business? So the first thing, understand what is happening and what's coming down the pipe. Then from there, one of the first thing I did when I opened my consulting office was to a friend of mine, a pediatrician. I did a cost analysis. How much does it cost me for real to see this patient? And that includes me paying a pediatrician to see it. And then from there, I will know whether I'm making money or not. And what are the alternatives? What is it that we want to sell to our patients what we think is best for them? But sometimes you have to sell to the patient what they want. So I go back to Dr. Henley and myself. He wanted to open the Medicaid office, primary care Medicaid. I told him, no, let's keep pushing the weight loss. Because with weight loss, Medicare patient wouldn't pay me $1 to do a full physical comprehensive metabolic panel, EKG. But that same patient, if I sold it to them as weight loss, they will pay me $300 to have the same thing done. So
Yeah.
is how do we work with the patient so we can do what is best for the patient? So managed care, Medicare Advantage is here. It's going to stay. It's going to continue to see a lot of changes, but they are struggling financially. And they are passing some of that and more to the providers. So how do we play with them? How do we keep our eyes with them? Again, this is something that I'm trying to give you an overall, I would say, information about what is happening. Kind of funny, when I started working on this, I used an AI.
Yeah.
And actually, I used 3 different AIs. All 3 AIs presented a rosy picture. Everything is fine. This is great. The numbers are good. The number of patients are growing. And I say, wow. So this, I'm going to throw it out there. Is there something going on with AIs that are being put there so that certain message doesn't get across? Because I actually had the data, I did the research, I look at the different states, and even me providing that information to the AI, is still wanted to paint something that everything is fine. There are no problems with the Advantage Medicare. No,
Well,
that's not
I
true.
would say that it's not necessarily, in my humble opinion, it's not necessarily that AIs are being how can I put this,
Manipulated.
monitored or pruned, but garbage in, garbage out. If the only information the AI has to draw on is the information that's being released by CMS and by these for-profit companies that want to keep their shareholders happy and their stock prices high, then you're going to get a rosy picture. The
Yeah,
AI isn't looking deeper into the information.
yeah.
It's not cross-correlating yet, as far as I understand it. It's taking a very 10,000-foot view of what the information is and then spitting out a report, but it's just garbage in, garbage out.
In a way, yes, but I actually gave them even the quotes of the places where I knew the reports, even the reports from the OIG. And it was funny. Like I say, this is not here, not there. It's just that we need to understand what is really happening. We need to look at the facts. Forget about how we feel about anything. And then we need to look at where is it that we want to go. I don't remember the last time, I don't remember ever sitting down with a doctor that he say, okay, Jose, here's my business plan. Never, ever.
No. Well, they're
Even,
not taught business.
well, even some hospitals and CEOs, Jose, here's my business plan. I look at them and say, no, they're just basically sometimes it's, well, this is what the data is telling me, or this is what corporate is telling me to do. And no, this is a time for us to really sit down, look at what's happening, and how do we take control of the market in terms of what is out there that it merits me putting myself at risk, my money, for me to do what I want to do. Do I want to provide the service? Do I want to make money? Do I want to do a combination of both? There is a way to do it. I'm not saying it's easy. So my point is understand what's going on. Okay. So now what I'm looking at is, oh, okay, it's 2:21. I think that we have been going a little long with this very
Yeah.
heated
I mean,
That's
discussion.
good information.
for me, when it comes to the Medicare Advantage thing, there's been some interesting movement for me that I've been looking at, and I've been sending you some of it because you see more, you see certain companies that are saying, screw it, I'm out of Medicare Advantage. I'm having a hard enough time with the private market. Let some other idiot that thinks they can do it, do it. And then you have other ones that are taking the exact opposite approach that are saying, screw the private plans, we're going all in. And now a piece of me is thinking that this is just to set up a merger like Humana was trying to do with another, I want to say it was Aetna, where Humana was just getting rid of the private market stuff so that way they could avoid the antitrust
Yeah.
argument, because then Humana would be the Medicare Advantage side, and I think it was Aetna that was the full private, the private insurance side, so they could make that merger and make it worthwhile for both companies. Because you couldn't do, I don't see how it's feasible long term either way,
Yeah.
right?
Well,
Because
the
go
problem that
ahead.
I see, Jose, that I'm seeing is that these same companies are coming in, and after they have 1,000, 2,000 patients in any one market overnight, which is not really overnight, but next year they're gonna say, guess what? We're pulling out of the market all of Medicare Advantage products. So what happens? All of a sudden, you have all of these patients that have no insurance, and then they pull out. Will you be able to see them? It depends. Where are the patients going? And they may go to a completely different product that is only accepted by your competitor. So we don't really have control of the market, but it's already been said that coming up October, we're going to see new lines being drawn in terms of the Medicare Advantage, what products, what benefits, and who's going to play in where. And we don't know how does that look yet. So we're going to have to
No, of
wait a little
course.
longer.
Of course. But even in our anecdotal model at the mental health practice, and then looking at the market the way that it is, if I'm Ray, or if I'm in my case, I've got a young family, it's not worth it to me to pay for health insurance other than to have a catastrophic plan for in case, my kid breaks his arm because he thinks he's a bird and jumps off a couch. Like it's like it doesn't make any sense because I'm paying for the four of us, it'd probably be $1,000 a month with an $8,000 deductible, and the copay would be an equal amount. So before I get one red cent from the insurance company, I'm paying $20,000,
Yep.
more or less,
Yes.
like actually closer to 28, because between the max out of pocket and then the deductible, I mean, we're looking at $28,000, and then it resets every January.
Yes.
Be damned when I picked up the insurance. So at $28,000 a year, I mean, I can negotiate an orthopedic surgeon to fix my buddy's arm.
Okay, so let's look into this thing, Jose. The key thing here today was to tell people about the Medicare Advantage, which is also known Medicare Part C. Telling them also, number one is kind of how it plays, what is MRA codes, how do they get paid, the difference between fee for service and what we know as capitation, they call it value care, but it's basically risk payment. And then, of course, showing that even that market where we are being pushed into, that is having some difficulties, that it will make it very difficult to generate profit unless we are proactive and create the measures in our offices to be efficient, to use resources in the right way, so that we can not only pick the right patients, but also that we can get paid appropriately. And whether that means that maybe I'm not going to go full risk in my whole office, maybe have a mixture. Maybe I want to build up the cash with some kind of concierge service that I don't necessarily call it concierge. It depends on how you play it. So the key thing is, what are the alternatives for me to move forward? Because like you say, Jose, there are people that won't be able to afford health insurance. I mean, I know doctors that cannot retire because they cannot afford I would say the medication and the health
That
services
they're on.
they need. Pardon me?
The medication that they're on or their spouse is
Yes.
on. Yeah.
Yes.
That's a wild statement to make too. And it's sad that it's happening. But I mean, so I guess the big thing would be this, guys. Take a look at your payer mix. We're in August right now. If you're gonna make a move, I highly, highly, highly recommend that any letters that are being sent out, that you send those suckers out in the next 45 days
Yes.
and start the year off fresh. Because guess what? It's deductible season in January. So they're gonna pay cash anyways.
Yes. Yeah.
Very true.
It's about that time. You know what I mean? So if it's even on the table or something that you want to discuss, this is the time to discuss it, look at it, and then act quickly.
Yeah.
If not, you're gonna be SOL, and then it's never gonna be a bad time, but it's gonna be a worse time. It's gonna be harder for the patients to really come to grips with it and get them used to it.
Yes. Okay, Jose. So, but again, for our audience, what I
Yep.
want you to know is we are actually, from the standpoint of compliance, we're actually adding and creating new policies, forms, procedures to help you. We're going to be adding more courses. So I'm looking at this from the standpoint of how do I help you stay in business? And of course, at any point in time, this is also a reason why we're doing this. I was hoping to answer more questions than generate questions, but I think that after you read everything, you have more questions about what to do and where to do it. But at least you get a candid view in terms of this is the market. So the question that I'm going to ask anybody first is, what is it that you want to do? And then we can start from there. Okay. With that, I think that I'm done. Ray,
Dr. Delgado said he's done. I love it.
yeah, it's too serious. I got other things.
No,
So,
no. We gotta go. So then, Ray, what do we have on deck for next week?
Yeah, so everybody, I appreciate your attendance today. We're going to be revisiting, I should say, the Ascension Health, the Change Healthcare cyber attack, and then we're also going to talk a little bit about the CrowdStrike event.
Yeah, I remember that one. That was the fun title we came up with.
Yep. It's it's going to be a good one, and it'll be interesting to talk about. We weren't affected here at EPICompliance, but I have a buddy that works for Amazon that their systems were down because of that CrowdStrike. Obviously, the airlines were down. It caused a whole mess. So
there were whole hospitals that were down.
Hospital systems were down.
Mm-hmm.
And that wasn't even a breach. That's the funny part. It took me 2 days to get home from.
At
that rate drive, 2 days. You could have just driven at that, like.
That's crazy,
but yeah. So I mean, we're going to be talking about all that stuff. And the other two should be a great quick recap, because there's a few things that have changed on the Ascension Health side. A few things, not much has changed on the Change Healthcare. I think they're genuinely hoping that everybody forgets, but
never forget.
But there's a few little updates, so we'll go over those, and then we'll go from there. Answer any questions or concerns. All right.
Sounds good. Well, hey, Dr. Delgado, appreciate your time. Jose, yours as well. We'll certainly
always
dive into that next week. And if you guys have any questions, concerns, please feel free to reach out. This
topics.
Yeah, we ask this every webinar, but if you guys have any topics that you'd like us to discuss, let us know. We're certainly open to that.
Yep. Have a great afternoon.
Thanks, guys.
Thanks, Dr. Delgado. You guys take care.